instrument assist soft tissue mobilization. Today is very happy we invite our speaker, lecturer, Natalie. She is coming from Australia. Officially, she is the first time in Hong Kong. Why officially? Maybe you can ask her. Natalie is a very senior physiotherapist. She is specialized in manual therapy, so she is using a Herbert tool to add a treatment protocol in the daily work together with a shockwave for the tissue mobilization. So because tonight the schedule is very tight and concentrated, officially it is 8-hour workshop, but we make it short because before Hong Kong style. So let's give a big hand to Natalie.
I think I'll be fine without it.
Okay.
Can everybody hear me fine? Yes. Yes, thought so. Okay, thank you very much. As Jason just said, it's an 8-hour course that we'll be compressing to 4 hours, so I'll be talking very quickly. I would like to keep it fairly informal, so I like to have lots of questions and lots of feedback, so please, at the time, if you have any questions, ask me straight away. I do find that if you wait until there's a better opportunity, you've either gone to sleep or forgotten what it was, so ask at the time. I like to have it very interactive. As Jason said, I've been a manual therapist for nearly 30 years. Done a lot of sports stuff. I've travelled for a decade with a stunt group called Nitro Circus. Some of you may have heard them, but they flip motorcycles, bicycles in the air, and mostly land, but sometimes they don't very well. So I see quite a lot of injuries, a lot of peripheral injuries. Also done a lot of Olympic level elite athletes. But the majority of my work is really just seeing everyday people with everyday injuries. So I know we've got a mixed group of people from private practice to hospital, physiotherapists, personal trainers. We got any chiropractors? No? Okay, so obviously as a physiotherapist I'll be speaking in physiotherapy terms, but ask me questions as we go along. Basically, I've always seen that the greatest tools and equipment that any therapist can have is your hands. The information I get from my 10 digits is all the information that I need to treat effectively the vast majority of conditions that I see. So I've been one of those therapists that really has struggled to adopt anything else, any piece of machinery, any equipment. I've always gone, unless it can do as good a job as my hands, I'm not interested, because I got such good results with my hands. So it was an interesting challenge to me to think, well, why would I bother using these tools? And then I realised that the tools were just an extension of my hands. More than anything, that the tools could buy me time to use my hands. Because one of the things that these tools do is it means that you don't have to work as hard through your fingers. So you can save your own hands from things like osteoarthritis and fatigue and that sort of thing. So it's very important to understand that the tools don't replace your hands, they enhance them. Okay. There's also another level of information that you can get when using the tools that's different from any manual feedback that you might get, and we'll go through some of that when we're doing some of the scanning techniques. But it's actually possible to get a different feedback, particularly with the fascial work that we do. So, sometimes it's easier feeling the muscular tissue, and I personally find it hard to differentiate between muscle and fascia because they're so connected to each other. But you'll find that with use of the tools, you can actually feel different sensations and vibrations coming through the metal. That's very unusual and not something that I've ever experienced just with my raw hands. Okay, those corrugations and things that you feel in the tissue that you can feel with your fingertips actually gets enhanced and amplified through the metal. So it's quite fascinating to feel it, and the feedback that I get from using the tools is far, far greater than, in some instances, than what I can get with my hands. Okay, can you see? I'll move out of the way a bit. There we go. Okay. So very briefly, the history of IASTM is actually a traditional medicine one where they used scraping, and I think you know, people have used the Chinese spoons and buffalo horns. Most of that sort of work is a lot more superficial than what you will get with the Hawk grips tools. This is not an effect that we get with Hawk grips. It's a much deeper effect into the fascia and the lymphatic system and into the muscles, rather than a scraping and a scratching of the skin. So you might get an erythema, but you wouldn't actually expect to get this sort of a picture from a patient. The Hawk grips tools themselves are really just a sophisticated version of those traditional tools, but they have been very, very well thought out with their engineering. You'll find, hopefully all of you have a tool that it's got quite a grippy resistance to it. The friction surface on the tool means that you can hold it very well in your hand. It doesn't slip, particularly when we're using the emollient. There are certainly other tools that are available that are arguably cheaper, but they are a very smooth metal, and you find that they will actually slip in your hand when you're going to use them. And it's important that contact that you have with the metal is actually very, very important to get the good treatment outcome. Okay, as far as treatment precautions go, they're similar to most manual therapy precautions. Obviously, anybody with a significant blood disorder that's going to increase the likelihood of them bleeding, so anticoagulant therapy, or any blood clotting disorder that they may have systemically. One of the other interesting ones is the chronic regional pain syndrome. It has a number of different names, but what we know with those sorts of patients that sort of hurt from head to toe, that any form of manual therapy can actually make their condition worse. So this is no different. The manual therapy doesn't tend to work particularly well there. And yes, you know, your usual post-surgical, you wouldn't do it over a fresh incision or you know, obviously an open wound or anything like that. There we go. Again, as with every technique, you would be advising and informing your patient as to what it is that you're going to be doing, getting their informed consent that it's okay to do it. Other obvious ones are over a new hematoma, or if you suspect that there's myositis ossificans present, because again, this is a manual technique, so we don't want to be stimulating any bony laying down into a hematoma and getting myositis. I would be hoping that nobody would be doing manual therapy of any kind over a fresh fracture site. So again, most of these contraindications are just common sense physiotherapy contraindications for all sorts of manual therapy techniques. Okay, some of the mechanisms of action that we have, there's quite a lot of research coming out about the use of the tools and why they have the effect that they have. There's some neurophysiological effects, mechanotransduction effects, the breaking of crosslinks with some of the techniques, and fluid dynamics, so your lymphatic flow all get altered. These sorts of concepts are explored in a lot more depth in the level 2 course, so we won't spend time on this tonight. I think tonight the important thing is to get you using the tools and having a play and seeing what sort of wonderful effects that you can get by using the Hawk grips. Okay, what we do know, however, is that those mechanical forces really change things at a cellular level. And it's a similar thing as to what the piezo wave, the shock wave, does too. By sending a mechanical force into the tissue, you elicit a response from those mechanoreceptors that very cleverly translate that information into a chemical signal. And one of the excellent things that certainly the piezo wave does And potentially some of the manual therapy techniques that we do is the activation of stem cells. So as we know, stem cells is the template for all tissue, so you can actually generate a repair response by activating those stem cells. So there's a very excellent article that I can certainly give to people relating the physiology behind all of that. Let's go. Where's my magic hands, man? It won't go. Oh, here we go. All right. Yeah, you're going to have to race up if it doesn't work. It's fine now. Okay, so very quickly when we're going for treatment, because it's a manual therapy technique, obviously having increased blood flow to the area already can be very valuable. So you might do your subjective and objective assessment as you would with any patient, any condition, any treatment. Doing a brief warm-up could be very valuable. Obviously advising the patient what you're going to be doing. Do your treatment, reassessment, and then whatever you wish to continue. So again, it's just incorporating an absolutely normal physiotherapy program, treatment program that you would be doing. Okay. This really doesn't like me. Okay, so hopefully you've all got a tool in your hand. So if you can just have a look at the tool for a moment. I think it's important to remember that you can feel that they're quite weighty. Okay, so one of the advantages to using the metal over your own hands is that the weight of the tool itself will give you a certain degree of tissue depth, so that you aren't having to press hard. You're really resting the tool on the tissue. You don't have to forcibly use it because the weight of the tool will actually allow that tissue depth that we're after. So there is a variety of instruments, shapes, in the complete set, and the different shapes are very cleverly designed for different purposes. They're also designed to more closely meet the contours of the body. So as we explore the tools tonight, you'll actually see that, it's amazing how very, very neatly, this shape will fit that contour quite nicely. Okay, so the different shape tools are for one for different purposes and two for different parts of the anatomy. Okay, so the convex surface is usually for really specifying tissue, and for a smaller area. The concave surface obviously will capture a larger surface area, a broader area that you're actually going to be working with. Okay, if you look at the treatment edge, you'll see that it has a distinct bevel on it. So a downward angle of the tool, and that is the treatment surface for the vast majority of what it is that we will be doing. Okay, most of the time, the bevel essentially dives into the tissue. If you have a look at it, it contours downwards like that. So that is the vast majority of the treatment surface is with that bevel diving down into the tissue. Okay, you can turn it the other way up, which is a much softer surface, a much smoother surface. And that one is mainly for lymphatic drainage and just sort of a general soft warm up to the tissue. So more often than not, the beveled surface diving into the tissue is the way that we're going to use it. Okay, you might use it the other way up if you just have those patients that when you touch them, it's like they're very, very sensitive, and you just need to desensitize the superficial skin. So you would invert the tool and have it on the softer, rounder surface. Okay, the treatment angle is around about 30 to 60 degrees. Okay, you don't want to come in too steeply because you'll dig in too hard and it will be quite painful and unpleasant for the patient. You're just wanting to glide across the top of the tissue, so at around about a 30 to 60 degree angle with that beveled edge going into the skin. Okay. You'll notice that the instruments themselves are, you know, as I said, they're very durable. The Hawk Grips gives them a lifetime guarantee, so unless you run a truck over them, if you happen to drop them, if you happen to bend it somehow miraculously, that will be replaced. But hopefully from the tool that you have in your hand, you can appreciate that it's actually quite difficult to do any damage to it at all. And in that respect, you know, it's one of the things I love. They don't wear out. They never die. They don't have to be maintained. I can take them with me on the road whenever I'm touring with a group. They go into my hand luggage or into my checked luggage. I don't get stopped at security with them asking, you know, what sort of piece of equipment this is. So they're very user-friendly and they're very travel-friendly. Okay, and if you work out, you know, cost per day for an investment, you'll have them for the lifetime of you as a therapist, so the cost per day is minimal. Okay, they don't like being dropped on hard surfaces though, so that said, I suspect if you drop it on a hard tiled surface, the tile will be the one that comes off second best rather than the tool. But we still don't recommend that you throw them around the room. Okay, let's now get on to the strokes. I'm going to just demonstrate each of the strokes to begin with to give you a bit of an overview, and then we'll very quickly get into the practical segment so that you can start getting yourselves familiar with the various instruments that are available. Okay, the first one is what we call scanning. So you can do these techniques with most of the tools, but the preference is this one, which in Australia we call the Sydney Harbour Bridge. So we call it the bridge for obvious reasons. So you can come up with your own Hong Kong related ones. I haven't seen enough of Hong Kong to know some famous landmark that might look like that.
One of the things with the anatomy trains is thinking of the wave of the tissue ahead of your force application. So again, the same sort of thing with this, that you can both see and feel that there's actually a wave of tissue ahead, and you'll get to spots where you kind of go, oh, okay, there's some resistance coming in there. All right, so this is kind of like an overall picture of, well, what's the tissue doing, and then I'm going to decide that there's specific areas that I then may want to focus on doing a particular technique for. Okay, so that's your scanning one. Okay, you can also do the sweeping with this one, again for a larger surface area using the concave surface. You can come down, because it's a narrower one, it's quite hard to do it with two hands, and I'm very right-handed and I like to have the other hand in contact. So I'll tend to do it more like this, or push the tissue up. There's no rules, it's really about what you feel comfortable, how you use the tool. And I think of, you know, how people, not that people write anymore with pens because everybody's on keyboards, but you know, different people will naturally hold pens in different ways. So I don't want to tell you this is how you have to do it. I want you, as I said, to have it as an extension of yourself and your hands, so you do what comes naturally to you. And I said I just like doing extra work with this hand, just feels normal to me. Okay.
So is that more for just assessment than just using this tool?
Both, yes, good question. So is it just for assessment or is it for treatment? It's actually both. So you will feel very lightly through the tissue as a scanning kind of motion and feeling those corrugations, which is harder to feel because this one's narrow. The easiest way to do it is without. And then you'll actually focus in and do some specific stuff like that. Okay. And then the handlebars one, which everybody loves. Okay. The handlebars for an obvious reason. It's like handlebars. So same sort of thing. This is really very heavy, so it's very good for your larger surface areas, so your quadriceps, your hamstrings. And even though you can apply a lot of force, you really don't need to. You can just rest it onto the skin and work your way through like that. Okay, so just sweeping through. Okay. What's happened to our... And as its name implies, it's basically doing a pin and fan motion. So you'll stop one end of the tool and fan it round the top. And again, you can use any of the tools to do it. This one I've always liked using. It's like putting butter on bread, essentially. So, very fancy. Alright. Okay, the next one. Same sort of thing, it's just another fanning with a different tool. Same sort of technique, it's pin and swipe, so like a windscreen wiper, which we used today. Got a lot of rain today. We were in the middle of it. It's very wet. Okay, very easy sort of stuff, very common sense techniques with these. Okay, now the next one's the brushing. So as its name implies, it's thinking of it in terms of, using a paintbrush. Again, when I first was shown how to use the Hawkrex, the person sort of used it like this, and I really didn't feel comfortable sort of doing that at all, and I just really didn't like it. And then one day I just sort of picked it up more like
A pen or a paintbrush, like I would write with it, and hey presto, we can get in and do some brushing strokes, as its name implies. So very good for ligament work, very focused work. If you really identify with the scanner that there might be in the VMO, there might be some increased resistance and increased tone, and you might specifically want to get in just to some specific spots that you pick up with the scanning. How's that feel?
That's okay.
Yeah? Okay. The brushing technically goes with the line of the fibres, and then we have the cross friction or the strumming, which goes across the fibres, as its name implies. So you might do some cross frictioning, again, medial collateral ligament damage, and you're trying to restore some of the integrity to the ligament, and you'll get in and do the cross frictioning there in the opposite, perpendicular to the line of the fibres. And that's one of the things that I've found that's been really quite fascinating with the ligament work that we do. With the Nitro Circus boys, it's a pretty brutal, they get paid very well, but it's a brutal pay structure that if they don't perform, they get no money at all. So there's a lot of pressure on them if they happen to injure themselves in the middle of the show to try and get back out there. So there's a lot of pressure on me to get them back out there. And one of the ramps, there are a lot of peripheral injuries and a lot of sprained ankles. So we developed a technique that, most therapists would probably suggest that a lateral ligament sprain would be out for 3 weeks, 3 to 6 weeks. Would that be what you'd say? Give or take? Yeah? Okay, we have them back in one show. It's a slightly brutal technique, so normally I used to get in with my thumbs and the patient would scream, but you could feel the ligament sort of sitting up, and by cross-frictioning it, it would actually flatten out and their pain would just completely go away. And they were prepared to put up with the pain of treatment because there was a significant reward at the end of it, as in, I can go back, I can perform, I can earn $1,000 a trek. $2,000 a trek. So fairly high monetary incentive. The interesting thing with this is that I do the same thing and it just doesn't hurt as much. Now, I have no explanation as to why that is, because you'd think that a nice soft thumb would be much less painful than a piece of metal, but I do the same cross-friction technique on the lateral ligament of the ankle that would have them screaming with my thumb, and it's unpleasant, but it's not horrifically painful. And I have no explanation as to why that is. Play around with it yourselves, but it's a fantastic technique, and we get much, much faster results with actually getting in and treating lateral ligaments, or actually all ligaments, quite aggressively very early on, rather than do the usual RICE and immobilise kind of thing. Happy to chat to anybody about that later. Thank you. Perfect. Okay, so the framing is also using this particular tool where you might be basically getting in around a kneecap, going through all of the retinaculum that's through there, loosening all of that off. So if people have patellofemoral dysfunction and they haven't got that nice medial lateral glide, if they're a bit stuck in there, then just as its name implies, you're really just going around the anatomy. So another nice place is in the greater trochanter, and you think of all of the muscles that are attaching in there, that the muscle will be pulling on its insertion if it's very tight. So getting in and doing some framing work to alleviate the pull either on the bone or at the musculotendinous junction. So that tool is one of my favourites in those sorts of terms. Okay, and the last one is the J stroke. As its name implies, it's basically a line forward with a bit of a scoop at the end. So you're you're sort of burying the medial aspect of the tool into the tissue and lifting up the lateral aspect a bit. It's particularly good for the erector spinae when you're trying to, it's kind of a combination of a brushing and cross friction, that you're going with the tissue and then across the tissue. It's also nice to come in, and if you're trying to identify the fascial planes as they come down the anterior chain or the posterior chain, and you're following the fascial planes, getting in and doing the J stroke like that is just a nice way to work your way through the fascial plane. Okay. Okay, now as far as dosing goes, again, there's no great science behind it. It's a bit like you think of your other manual techniques as, I know we love to put objective numbers on things, but really what you're looking for is a change in the body. So a feel, you know, when you've done that scanning and you've felt the corrugations there, you've felt the tissue resistance, then you're going to treat until that changes. There's very little purpose stopping a treatment because some lecturer said it needs to be done for 30 seconds. If the tissue hasn't changed, it's all fairly pointless. Okay. It is, however, important that you don't over-treat. So the Hook Grips group recommends that you really only limit it to about 30 seconds at any one time, and then let the tissue just recover, and then you might go back and do it a little bit longer again. So I think if you think of cooking meat, it's always good to rest it. It's more tender if you rest it. The blood gets absorbed evenly throughout the meat. And I think of it in a similar sort of way in living meat, that obviously you're having an effect on blood flow, you're pushing the fluid dynamics around, you're sort of upsetting things a little bit. So you give it a little rest, let all of the blood flow and the lymphatic flow return to normal again, and then go back to it if you feel like it hasn't finished. Okay.
How long would you normally give?
I knew that was a question, but it's not like I sit there with my watch and go, but yeah, I probably do around sort of 30 seconds, you know, on one particular area, and then, you know, I'll come and do another area, and then I'll come back to that, and I'll have a little feel and go, yeah, you know, that's changed, or it hasn't, we need to do a little bit more. So I really don't like working with numbers. I hate numbers. I'm very much about the feedback, the outcome, and you will feel it change, and as soon as it changed, job done. And some patients, you might just do that for a few seconds, and it's like, oh, okay, it's already changed. So we're so complicated and unpredictable that I don't think we can possibly put parameters on. And it depends on what you're treating. So again, if those familiar with the anatomy trains concept, you'll be aware that the fascial tissue it takes a longer time for it to let go. It's a very gentle sort of easing approach, but it's slower. Whereas you think of muscular tissue, muscle tissue has the capacity to turn on and off in a millisecond. Contract, relax. And the same thing happens when you're treating, that you can go from contracted, high tone, resisted tissue to, oh, okay, it's suddenly let go. And that varies. It also varies on the chronicity of the patient's condition too. So, I do a lot of complex and chronic spine treatment at my clinic. That's kind of the mainstay of what I do now. I get sent an awful lot of chronic spine, and when you get that really rigid group of erector spinae, it takes longer, but we just quietly work away at it. But you don't end up stripping them like the first photo. But yeah, as I said, the feel thing with the fascia, and remembering that it's a more gentle stroke that takes a little bit longer. Your obviously acute injuries on the whole, you're really trying to get rid of that effusion that might be there. So if we are treating, say, a lateral ligament, you might approach it a little bit more conservatively, a little bit shorter time. But even then, like I tend to treat until I feel the tissue has changed. If the patient is feeling that they're getting a little overwhelmed, if it's an acute condition that you're treating and they're sort of, the pain tends to build up a little bit as we treat these things, then obviously stop, give them a little bit of a break. A couple of seconds is all it takes, take a breath and then go back to it. So the more chronic things where you're going to be getting some collagen being laid down, you're trying to get rid of those cross-links that are occurring in the tissue, maybe get into scar tissue. You can go a little bit firmer and a little bit longer with your treatments, and it will be tolerated much better by the patients. Okay, very quickly, I'll introduce you to, I guess, a background thinking as to, you can sit down, thank you very much. Like when I incorporate the tools and why I would incorporate the tools. So I look at, in a history, I will look at whether I'm hearing a story of potential damage or potential dysfunction. So when you think of damage or destruction to perfectly normal, wonderful human tissue, there takes quite a force to tear a muscle or a ligament, all right? To tear a piece of paper, you have to apply a bit of an acceleration force, otherwise you bend it, okay? A bent piece of paper is not damaged, okay? It's not perfect, but it's not damaged. So, and I can assure you ligament and muscle tissue is much stronger than a piece of paper. So your damage situations have a defined moment in time where there is a force, usually an external force, great enough to justify damage to otherwise perfectly wonderful tissue. Okay, then you're going to create an effusion, you're going to create swelling, you're going to create some blood vessel damage, so there may be a hematoma that forms, as opposed to your pain that really comes on without much of an event. Now, in 30 years of clinical practice, I've never had a patient come in and say, I don't know why I got my pain. They come in and they tell you some story. Oh, it was probably that box I lifted up yesterday. And you kind of go, but you've only just got the pain today. Yeah, but they will look for the most exotic thing that they've done in the time period to see whether they can make some sort of sense of it. So I think it's funny because particularly with chronic pain, I find that patients will make up a story that justifies the onset of their symptoms, then they believe the story that they themselves have made up, which is why they don't seek treatment until it happens again or again or again. So you get this cumulative error, and then by the time they see me, they're a mess. Okay, so the dysfunction story is more that you've either had a gradual onset of pain or you've had a few small episodes of pain that have gone away by themselves and then come back again miraculously. Or really there's no real punishment. They're just trying to pin it on something. Now, why is that important? It's important because I think you can look a little deeper when you're doing your treatments beyond just the initial clinical presentation. So I've done 30 years of treating elite sports, Olympic level, and as I said, travelling the world with a sports team, but I've never called myself a sports physio. because I don't believe personally in sports injuries. I believe in sports accidents. Okay, so a slide tackle coming in, taking out a knee, a tackle sort of man-to-man with rugby. I'm not familiar with what your sports are. I think you play rugby here a lot? Yeah? No? What are your sports here? Soccer? Soccer? Yeah, okay. So, you know, running along, rolling your ankle and doing your lateral ligament, that makes sense to me. But if you're playing soccer and you go to kick the soccer ball and you tear your hamstring, it doesn't make sense to me that I would define that as a sports injury. You've kicked the soccer ball 1,000 times before. So why this day did it go? To me, that's cumulative error that's met with a moment in time where the body's failed. So I say to patients, the sports injury is a bit like saying, I went for a run and I had a heart attack, and blaming the run. Okay, when you have a heart attack from a run, it's not because of the run. It's because you have a problem with your heart and you've loaded it. So what a surprise, when the heart's been loaded, it fails. Now what's sport? It's velocity, it's resistance, it's load. So one of the things to think of is when you're looking at the history of any condition is, okay, is it a force that's great enough that justifies damage in that moment in time? If not, even if I'm dealing with damage, I have to look at a background of dysfunction, okay? And we'll incorporate that a little bit more with the hawk grips as to why you would go looking for different things with the tools based on what you're seeing from that history and from that initial presentation. But all right, for now, let's break out into the beds and have a start playing with some of the tools. In both circumstances, that with tissue that is both shortened and elongated, you can end up with irritated tissue that is painful. So the treatment techniques that we're doing is to calm down the irritation, not necessarily to elongate tissue, although it will have the effect of elongating shortened tissue. Alright? So our aim is to reduce the patient's pain, because if we don't take away their pain, we tend not to get much compliance for anything else that they do. Okay, so first and foremost, we have to hear what our patients want from us as therapists, which more often than not is, please take away my pain. Okay, we do that and we gain their trust and they understand that we know what we're talking about, because it's like, oh, my pain is gone. Then it invites the next stage of the communication, which is, this is why you got your pain and we need to address that. Okay, so then it's a case of using all of your other therapeutic, tools, I guess, that you have. So if somebody's been like this, right, and you want to elongate the tissue at the front and you want to have the thoracic spine in a better position so that the shoulder girdle is sitting better, you might be getting them to do pec stretches. Why? Because this is adaptively shortened tissue.
Adaptively shortened tissue responds to stretches. Actively shortened tissue won't. Actively shortened tissue has to be offloaded. So your glutes, if they're trying to control a pronating foot, that's an active shortening. So doing lots of glute stretches may give you temporary relief at best, but fundamentally will never fix the problem because the problem is a load problem. You need to offload. Does that make sense? Okay, so it's another reason why, like you see, I never understand the swimmers that are like this, and then they do all these stretching exercises. And you go, you're already elongated there. Okay, one of the reasons it hurts is because the tissue is elongated and reefing on the attachment. So you can ease that by getting them into a better position. Right, so just think a little bit more about the background of, unfortunately we use the same language to describe two completely separate physiological events. We use the words tight, don't we? We use the word like tight, active or passive. What do we mean? Yeah, the tissue is, we use the word short. Is it an active or a passive shortening? Right. So you need to be mindful about addressing the issue that is in the tissue, and if it's an active shortening, it needs to be offloaded. If it's a passive shortening, then it will respond to stretching. Okay, does that make sense? Yeah. And in all circumstances, what our first intervention is to alleviate the symptom that the patient came in with. And then you talk about the story as to why, and some way do. Now, we've had some questions about the shockwave, the piezo wave. So I've been asked to just do a little bit of demonstration with regards to this machine. As I said, I've been a manual therapist for nearly 30 years, and I just refuse to use things that plugged into the wall. When I was trained, we had things like ultrasound and interferential, and I was actually trained on something called shortwave diathermy. I don't know. Yeah? Do you still know that? Oh my gosh, I thought that's gone. And traction. We don't do that anymore either. So most of those electrotherapy things, certainly in Australia, that I was trained with have disappeared along the line. People still do use ultrasound, and I think it probably has a place, but a lot of the machines that I grew up with were really, I saw them as entertainment therapy. That it was things to just do with patients that maybe made them feel better because we told them it would make them feel better. But I never really put it on somebody and then went, okay, that's different. You know, there's a wow factor there. And so when I was in America a while ago, I was working with a therapist who said, have you seen one of these? And I went, plugs into a wall, I'm not interested. And he just went, oh, okay. And I said, if it doesn't do as good a job as my hands, why would I bother? So I touched the patient, and then he used this machine on it, and I touched the patient again, and I went, right, I solved it. Okay, because again, to me personally, it's that tissue change that I want, because to me, if the tissue hasn't changed, then why would the patient's symptoms change? I'm feeling aggravated, resisted tissue, and if I think that that correlates with pain, which I'm pretty confident it does, that has to change for me to be excited. So I started using this. And as I said, I in particular see a lot of very complex pain patients. And I've had patients, I don't know if you've had them, but you know, you go to sweep across the gluteal muscles and they'll squeal like you've just grabbed a handful of glass. And they're so sensitive. I'll treat with the piezo wave for maybe 5 minutes, not even beforehand, and I go to touch the patient again. Not only has the tissue calmed down, but they have zero pain. One of the other things is that our treatment technique, again very manual, we used to elicit bruises quite readily from patients, which in Australia and the USA is highly undesirable. I know that Eastern medicine approach with an erythema or a char it's a good thing. That's a cultural difference. It's a bad thing in Australia for some reason. And we would find that at the very beginning, the patient is at their worst the first time they come to treatment, not a surprise. And that erythema, that bruising would happen very regularly in that first treatment. And I spent a career saying if I could achieve the same outcome without hurting the patient, then I've struck gold. And hand on heart, that's what this machine enables me to do, because the patients aren't in as much pain while I treat them, and they're not getting the post-treatment tenderness that I've been used to for 20 years, patients complaining about. So the way it works is there's crystals in the sound head, quite similar to ultrasound, that the electric current goes through it, creates a very intense acoustic pulse. Now that pulse goes into the tissue, and again we're back at that mechanoreceptor on the cell membrane, so that information gets translated as a chemical response. It reduces substance P, which is a significant neurotransmitter. It activates stem cells and causes cell differentiation to occur. And the way I describe it to patients is it's like the government knows that there's an earthquake that's happened. So the government, not the Australian government, they wouldn't know, sends the army, okay? Because they go, oh, there's probably been damage and destruction. Send the army. And the army gets to your house and the army goes, well, there isn't actually any damage. The roof's intact, no cracks in the walls, but the books have fallen off the shelf and the chairs have all fallen over, and we're here, so let's clean up because we're here. And you get home and the place looks immaculate. So it's like it kind of almost causes damage to elicit that inflammatory response, and as we know, it's the inflammation that actually provides repair and healing. Inflammation is a good thing. It's got a bad reputation, but it's a good thing. So the piezo wave stimulates all of that chemistry to happen, and it can very cleverly switch out cells and put in new cells, and so we actually get a proactive repair happening. So has anybody, I don't want to, where's Alex? Has he disappeared? Has anybody else got something that might hurt? Otherwise, I would be very keen to use your other calf. Only because I know we've got a problem. Has anybody else got a musculoskeletal? Nobody got a musculoskeletal problem. Miracles. Do you mind if we use your other calf then? Yeah. Because Alex was such a good patient and ouched on cue before. Okay, so that's all pretty tender there, particularly right over that nasty bit there. Okay, so this particular, does anybody use shockwave already? Yeah? Do you have can you do the linear or just the focused? Okay. So the beautiful thing about this machine is that you can capture, lots of area, basically. So the focused one, which this also has, oh no, not that one, the other one. Oh, there's a focus probe anyway, but if you're getting very specific tissue that you might want to, one of these gels that's a much smaller area and you're getting very specific targeted area, or you can use the bigger gel. So obviously, again, similar to a sound wave, because it's an acoustic pulse, it has to travel through a medium. So we use the gel lines, the apparatus here, and then we're going to use it. I think we're going to use it. Where was my little before? Ah. Clever. Tricky. Thank you. Okay, so you can change both the frequency of the pulse and the intensity of the pulse. This will determine the depth of the tissue. So as the fingers come together there, you'll determine the depth of the tissue. So it comes back to your anatomy. How deep, what tissue am I trying to affect? And how deep do I think the structure is that I'm trying to affect? Okay. Now it makes a clicking sound. So we pop it on. Now can you feel anything there at all? So what we're looking for is to, basically it will be pseudo-diagnostic in that when you find tissue that is highly irritated, it will actually create an aching sensation. So we'll turn up the intensity. Does that feel up in there? Not really? I've been a bit lazy and just put on the sound head that was there. But you might be more specifically targeting, if you know exactly where it is that you want to. If you know exactly where it is that you want to target, then you'll be choosing a sound head that's different. But I still find that it's quite beneficial. Yeah, just to get the job done faster. So the question was, do I use the frequency of 8 normally, which is the fastest frequency? And yeah, it depends on the patient's tolerance, but the job gets done faster because what we're aiming for is about 2,500 pulses. So each click that you hear is a pulse. So the therapeutic dose is around 2,500 for most of the conditions. It's one of the, in the literature now, it's probably deemed to be the best treatment for plantar fasciitis. There is a new paper that just got released about the combination of shockwave with cortisone injections in the shoulder. But the conclusion was that maybe it was the shockwave, not the cortisone, that actually had the effect. So it said, watch this space. So I think it's probably one of the latest, greatest bits of equipment that's out there that actually does make a difference. And I basically I pretty much use the shockwave on just about every patient before I then get specific with the hot grips. Again, this will neatly desensitize it, calm the tissue down, and then I'll basically release the entirety of the system with the hot grips afterwards. And I've had patients come say they want a photograph with the machine. Ours is called Roxy. So they want a photo with Roxy. They like it. But there's not too many conditions that I don't treat with it. It can't go over lung fields because it is that acoustic pulse. And it shouldn't go over the brain either. I don't quite know what you would be treating up there. Maybe temporalis gets irritated, but yeah, you don't pop it over those. But yeah, apart from that, it's about fabulous for any inflammatory condition and proven to be very, very good for tendinitis. It's a bit like watching grass grow. And I think one of the other things that I was saying with somebody was asking about what tissue I would treat. So if I was treating the back, I would treat the entirety of the erector spinae, or if I was treating Achilles tendinitis, I would be releasing both the gastrocnemius and the soleus through the entirety of the muscle belly, because yes, the tendon itself might be inflamed, but it's inflamed because of the muscle action, so I need to reduce the muscle action and muscle activity. So we're pretty close to therapeutic dose there. Let's take that up. Now, if I've paid Alex properly, what's happening?
Less sore.
Sore? Less sore. And again, I'm pressing harder than I was before. You can probably see at the front there that I was scarcely indenting the skin before. So it's pretty wow factor as far as I'm concerned. And again, that was a bit of a half-done job, because I can still feel up here that there's, oh yeah, there's, but I didn't go up there. All right, so you can almost, I can feel where I stopped, and the tissue's actually that. Okay, which I didn't touch with the machine, is still irritated. So it's quite specific. And now that I've started, I have to finish it. Yeah, and see, this is what I've been putting patients through for 25 years, until I started using the shockwave and the pork ribs. Now we're going to get exactly the same effect, but we're not going to be putting the patients through this agony. Now, as I said, I cannot understand, I am desperate to understand how a set of metal tools hurts less than my fingers, but it does. There it goes. That face should be improving. There's a latent response between me noticing it's improving in your face. Is that easing that?
Yes.
Yeah. I can think of 3 patients that I was determined that if I just worked through the rotator cuff and I got into their infraspinatus and their supraspinatus, and they were squealing like it hurt. And I worked on one athlete. We were filming a movie, and she's a very tough lady, and she got a frozen shoulder after having surgery. And I had the opportunity to treat her every single day for about 2 hours at a time, so incredibly intensive. She wanted to do it. She wanted me to try throwing everything at it. And what I found was I could get the range to improve by maybe 10 degrees, but by the next day we were back at square one again. And that's when I finally gave up. I just manual therapy for a true adhesive capsulitis, I couldn't make any difference to anybody. And again, to me it wasn't worth the agony I was putting people through to achieve very little. So it's like, just ride it out. And yeah, statistically, yes, you can get the manipulation under anaesthetic. It fixes about 30% of cases. Cortisone fixes about 30. Hydrodilatation fixes about 30. Sadly, you can't add them all together and get 100%. But this is the only non-invasive tool that I've found does anything. And I haven't seen enough of them to honestly say, yes, it cures it. My husband, ironically, got a frozen shoulder. He chose the one thing that physios don't tend to help. And I only got the shockwave when he was already in the process of it defrosting. So I kind of went, it definitely helped, but I can't from personal experience say that, you know, it was the bee's knees, but it definitely helped. And the literature would indicate that it's got very positive effects.